Hi, my name is Kimberly LeBlanc, and I'm the Academic Chair for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm joining you today from Ottawa, Canada. I wish I could be there live with you in Abu Dhabi for the World Union. Hi, my name is Kimberly LeBlanc, and I'm the Academic Chair for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm coming to you today from Ottawa, Canada. I wish I could be there with you in person in Abu Dhabi. I hope you have a great World Union, and congratulations to Gulnaz and to her team for putting on what I know is an amazing Congress. So today what I would like to review with you is to talk about skin tears, but from a patient's perspective. So to give us other side of the picture, so to speak, of what it's like to live with a skin tear. So here are my disclosures. So what I really want you to do at the end of this session is to have a better idea about the lived experience of a skin tear. This is what Ottawa, Canada looks like in the wintertime. I invite all of you to come and visit us. So what do skin tears look like, and what's the big deal? Because too often we hear, well, they're just skin tears. And certainly that is something that actually is one of the reasons I got interested in skin tears, because I'd have nurses coming to me saying, Kim, can you come see this lady with a skin tear? Well, it's just the skin tear, but we think you should look at it. I thought, well, if it's just the skin tear, why do you need to have a wound care specialist come and see the wound? So I want to do a deeper dive into what it's like living with a skin tear. So I'm going to tell you about a lady that I met. Now, Andrea is not her real name, but it's Andrea, and she's a 77-year-old retired nurse. And she says that her leg looks like it's about 200 years old. And with every bump, I get a bleed and a bruise, and then the skin stays discolored. And she said, well, when I met her, she said, I'd had a fight with a garden tool. That was my attacker, and I lost. So you can see how she was gardening, and she accidentally slipped with the garden tool, and she created the skin tear on her lower shin. So she has a past medical history of asthma and a total knee replacement and atrial fibrillation. She's on Xarelto and bisoprolol, furamate, Singulair, Symbicort, Atrovent, and Mycardis. She went to the emergency department with a type 1 skin tear in her lower leg. In the emergency department, they closed the wound by primary intention and applied an antibiotic ointment and covered with a non-adherent mesh. And she received her tetanus vaccine booster and was discharged home with instructions to follow up with her family physician as needed. So what she reported was that the wound continued to ooze blood for about 4 days and resulted in a hematoma about 3 centimeters square. She reported she felt unsure of how to manage the wound, not knowing if to keep it covered or left open to air. She reached out to members of the healthcare team to learn more information about caring for her wound, and she was informed that she should apply the antibiotic ointment. So she said that she didn't have an appointment for stitch removal till day 10, and she doesn't have any home care yet. The skin around seemed to be reacting with redness to the tape on the bandage, so she put a bit of petrolatum jelly on it. So on day 10, the sutures were removed, the wound edges were unattached, and there was a circumferential peri-wound inflammation. The petrolatum jelly was discontinued, and the skin tear was covered with a non-adherent silver foam dressing. She said the doctor called me later to say that she had spoken to a plastic surgeon to see if a skin graft could be considered, and the reply was no, because the wound would heal in 4 weeks. The flap seemed to be intact, and so far, however, I'm not convinced it will survive. I'm going to call home care. So at this point, she was really feeling apprehensive, and keeping in mind she is a retired nurse. So on day 13, the throbbing pain started at night. The peri-wound was inflamed and her lower leg was edematous. She had planned on returning to the emergency department, but decided to wait and see because she wanted to spend time with her grandchildren. She could see that the flap was dying or already dead and should probably be debridement. She was living in hope. She continued to wait for a wound care specialist visit and a lower leg assessment, which she thought should be done. She elevated her effective leg to manage edema. The skin tear in the surrounding area felt itchy, prickly, with the occasional sharp stabbing pain. She was keeping busy with her grandchildren. It's too hot to wear compression. If the flapper's dying or dead, it is best to leave it sealed in place or to keep the wound covered while it heals, or is it better to debride and remove, exposing the inner tissue and risk infection? She had questions, and she didn't have anybody to turn to. She said, I can't see the wound clearly because of the location of my leg and the angle in which I look at it. I feel sometimes that my injury is treated as a minimal inconvenience. However, it seems very serious and upsetting to me. I'm worried and concerned about infection, and the healing process seems very slow. So in her diary she kept, she said, home care was here today and changed the dressing. I find my wound is looking better to me, not so red all around the perimeter, and the feel of itchiness of healing. Is it wishful thinking on my part? The nurse stated I could do my own dressing, which I can, but I want them to monitor it until I can get a response from the wound care specialist. And home care says that she probably won't get to see that wound care specialist. Her doctor has to carry on. She's starting to feel depressed and discouraged. So on day 30, so we're now well past when this wound should be healed, and it's now entering into that possible complex wound. So with the dressing change today, the entire flap sloughed off. The home care nurse noticed some hypergranulation in the wound. I asked about putting some gel on it, but she felt it was because the wound was too moist, so she wanted to put a dry gauze on it today. I wonder how painful it's going to be on my next dressing change. Day 40. The gauze dressing had to be soaked off, and there was a bit of dried bleeding and drainage. The wound itself didn't look quite dry. Home care at this point really wanted to leave it dry dressing. They suggested the hypergranulation was much better and was close to being healed, and felt left without a dressing as it would heal faster. I insisted on one more dressing. Then she said that on day 45, she finally had her visit to the wound care clinic. And this is where things started to change for her. She had a complete lower leg assessment. Her wound was debrided. She saw a dietitian. Her peri-wound edges were assessed. And she started with compression therapy and a moist dressing and a topical corticosteroid ointment for the hypergranulation, and no more dry dressings. She had an appointment to return in 2 weeks. And they're going to give the home care instructions on what to do. She wrote that so I go on with hope that the holes will fill in eventually and a totally healed wound will be the outcome. So she went for a second visit to the wound clinic. It's been 8.5 weeks now since the injury. And she says she's starting to get really tired of this, and the compression wraps are uncomfortable, but she hopes they're helping. So here we are. Seems to me it's getting very close to being done. I am somewhat confused by all the different instructions and approaches to my wound. I think that has been the most frustrating part of this journey. 23 weeks and my wound is finally closed. Had I been told at the beginning the journey that it would take this long, I wouldn't have believed it. She says she's grateful the attention that she received from her healthcare professionals. However, she knows that it would be a lot less stressful and encouraging had there been a consistent approach to care. She said, I suspect updated information and education is the key for everyone, from the attending emergency physician, wound care clinic, and home care providers involved. So when we look at that, you can almost feel her hopelessness and her struggles during that experience. Now, one of the things that we did was, and we have not published this data, but one of the things we did is we had some interviews with patients, caregivers, and nurses in late 2019 and early February of 2020. And so we talked to 10 patients, 5 caregivers, and 15 nurses. And so we asked them to discuss their experience with fragile skin and skin tears, pain, and the experience with healing and dressing changes. So if we look at some of the themes from the patients, they said that these wounds are extremely painful. They just hurt me. At first they burn, but over time they throb. I worry about dressing changes and pain. From the appearance, they look horrible. People will think I've been beaten up. The scars are embarrassing. Fear of reoccurrence. I constantly worry I will bump myself. It seems I just get one healed when another one appears. Sometimes I don't even know how they occur. I worry when I get dressed or bathed, no one means to hurt me, but sometimes they are too rough and my skin tears so easily. My skin always seems to tear when someone is helping me get up. I feel bad when someone tears my skin. Then we look at some of the themes that emerge from talking with the caregivers. Fear of judgment or being accused of abuse. People see the tears and look at me like I've abused him. It's horrible when healthcare professionals ask my wife if I've been rough with her. I feel like it's my fault. People think I hurt him. I worry what others think when they see his arms. Upset over suffering of loved ones. I hate seeing him suffer. The wounds look so painful. She just seems to get agitated when she has a skin tear. I worry about the pain he is suffering. I worry about infection and even more pain. Fear of bleeding. When she gets one of them, they bleed so much it scares me. I worry I won't be able to control the bleeding. He's on blood thinners. The skin tears bleed so much. Then we look at the nurses. And one of the things that came out was the minimization. Well, they're just a skin tear. They're minor wounds. We don't have to pay too much attention to them. They occur so often that it's hard to keep track of them. The fear of accusations of poor care. I worry that families will think we are rough with our patients. Sometimes it looks like they were abused when the reality is they barely bumped their arm. They happen so easily and we, the nurses, are judged poorly when they occur. And then we think about dressing selections. They say that they struggle to choose a dressing. I'm unsure of the best dressings. Acute wounds should be sutured, but it does not seem to work. So what are some of the lessons that we've learned from this? Well, when we look at Andrea's case, and when we look at some of the perspectives from our interviews that we did, we know that skin tears are acute wounds, that they're expected to heal in 14 to 21 days. Their management should complete a complete wound assessment and treatment pathways, and we should follow evidence-based principles of wound healing, and not to minimize these wounds. There's the importance of a complete lower leg assessment and application of compression therapy if indicated. We should not overlook this in individuals suffering from lower extremity skin tears. Remember Wound Healing 101, wounds do not heal on swollen lower legs. Wound management plans should be patient-centered with open communication between healthcare providers and the individual suffering from the wound. Andrea has taught me the importance of really listening to the patients and understanding the importance of involving them in the care, and just hearing the frustration, the fears, and the fact that for her, she had many months from July until December before this wound healed, and the devastation and the upheaval that it caused her. Research on skin tears remains in its infancy, and more research is needed to fully understand the lived experience of having a skin tear. We don't have any good, true qualitative research studies that really explore in a systematic way the lived experience of living with a skin tear. So I encourage any of you who are interested in doing qualitative research to really look at doing some research on the lived experience of having a skin tear. It's important that all levels of the healthcare team be educated regarding current and emerging evidence. Most importantly, moist wound healing, and involve the patients in evidence-based care and prevention. These are crucial if we want to move forward and really understand skin tears, but as well ensure that they remain acute wounds and that the majority do not become chronic and complex. I invite all of you to join us in May at the Canadian Nurses Specialized in Wound, Ostomy and Continence Canada's conference. And there's reference should you want to learn more about what little research there is available. So thank you very much for joining me today, and please feel free to contact me should you have any questions.